This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we're talking about strokes. There's no denying strokes are scary. For some people, maybe even too scary to think about. But that doesn't stop them from happening. And while many of us have been busy not thinking about strokes, the field has been calmly and resolutely advancing right under our noses. So today, let's try to take a little bit of the scary out of strokes with Dr. James Klaas. He's a neurologist at Mayo Clinic in Rochester, Minnesota, where he has seen stroke treatments advance in real time and seen how they help everyday patients. Dr. James Klaas, welcome to the show.
Thanks so much for having me.
We're thrilled to have you to talk about this very important subject. Let's start off, though, talking about you. You specialize in neurology, particularly strokes and brain aneurysms. How did you get interested in this field?
I was fortunate that I had amazing mentors and teachers both through medical school and residency, but it was really when my grandfather had a stroke that I got a personal interest and wanted to dedicate my expertise to the care of stroke and stroke patients. I also benefited from training at a time where there was a lot of advancements and really exciting changes happening in the field of cerebrovascular neurology. So it seemed like for a young budding neurologist, a very exciting field to go into and something that would be personally meaningful for me.
Would you be willing to tell us a little bit more about your grandpa and what kind of stroke he had?
He unfortunately had a kind of stroke that's really, really common where a clot forms in the heart and then travels to the brain and blocks an artery in the brain. The reason the clot formed in his heart is he had, unfortunately, a very common arrhythmia that occurs later in life called atrial fibrillation. Atrial fibrillation is a cardiac rhythm disturbance or arrhythmia that doesn't have any symptoms associated with it. So it's almost this silent risk factor or silent killer. And so he had a clot that went to his brain and unfortunately left him with long-term disabilities related to some weakness and cognition challenges. One of the things that really impacted me from a physician standpoint and seeing not only what my grandfather went through, but what my grandmother went through as the caretaker of my grandfather. And that's something that's often overlooked from the healthcare profession standpoint.
Absolutely. The mental health, the physical health of caretakers is something that can't be underestimated.
Yeah, I mean, to see how both my grandparents were impacted was difficult, but also very enlightening. So I make sure in my practice that when somebody comes in after a stroke and they're with their caretaker, whether that be a spouse or other family member or friend, I'd make sure to ask, how are you doing?
Yeah. All right, now let's get into some basics. First of all, when someone suffers from a stroke, what is happening in the body?
So stroke is an umbrella term that really covers two main categories of stroke. And the medical terms are ischemic stroke or hemorrhagic stroke. And ischemic stroke is by far and away the more common of the two categories. Is going to account for about 85% of all strokes. An ischemic stroke is when an artery that supplies blood to the brain either gets clogged or blocked, and that's going to deprive that part of the brain of oxygen and nutrients. So the brain is a very energy resource intense organ. It requires constant blood flow. And so any interruption in that blood flow is going to rapidly cause those brain cells to die. We call that cellular death infarction, and infarction is an ischemic stroke.
Got it.
Now, contrast that with hemorrhagic stroke. Hemorrhagic means bleeding. And so this is where an artery in the brain either leaks or breaks open, ruptures, and blood goes into the brain or the intracranial space. That is the more devastating and often associated with a much higher mortality or death risk for a couple reasons. First, that blood vessel is damaged, so it's no longer supplying the oxygen or the nutrients. The other part is you now have bleeding around that area, and that is now causing damage to the surrounding brain tissue as well. And so it's really two main effects of damage to the brain that really increases the severity and the mortality with a hemorrhagic stroke.
Got it.
Fortunately, only accounts for about 15% of strokes.
So just to recap, ischemic is a clot and hemorrhagic is bleeding, and both of them can cause a lot of damage. What is the difference between a stroke and an aneurysm?
When we're talking about stroke, we're talking about the interruption of blood flow or the rupture of an artery. One of the risks for the hemorrhagic stroke or the rupture of an artery is an aneurysm. So in the brain, the artery, it can have a weak spot in the wall and it can develop an aneurysm. And probably the easiest way to think about an aneurysm is thinking about kind of a balloon forming on this artery at the weak spot. In itself, unless the aneurysm or the balloon were to get really, really large, it really doesn't cause any problems. But just like a balloon, if it gets blown up too big, it pops. And you got bleeding in the brain. So the aneurysm is a major risk for a very severe type of hemorrhagic stroke associated with a lot of disability and a high risk of death.
Oh, boy. What is going on in the body that it says, I am going to have an ischemic stroke or a hemorrhagic stroke or an aneurysm? What's leading up to that?
So the main risk factor for stroke is age. So we see this much more in the older population, and that's just accumulation of a lifetime of stroke risk factors, other things that occur like arrhythmias as we age, the aging of our blood vessels, the aging of our brain. All of these things contribute to a risk for both of these types of stroke. When we talk about these subcategories, ischemic or hemorrhagic, there are many different entities that can cause either type. And so there are certain things that even in a younger population will increase the risk of somebody having a stroke. Some of these are modifiable, some of these are not modifiable.
Can you give me some examples of what is and what isn't modifiable?
There's chronologic age and there is your kind of biologic age. Certain people look or act or feel younger than they actually are. But age is one of those I would put in the non-modifiable risk. I don't have the ability to make anybody younger yet.
If you're 59, you're 59. You can't be 36. So that's one thing.
So within the non-modifiable, other things that are risk factors, family history, and maybe that's the genetics playing a role. And there's kind of race and ethnicity variables that can also increase a person's risk of certain types of stroke.
Are there just certain ethnicities that are more at risk, or is it linked to other socioeconomic factors?
Some of it is definitely linked to socioeconomic factors, but some of it can be independent. We see in the Black population a higher risk of hypertension, and so we can see that as a major modifiable risk factor for stroke. In our East Asian population, we can see a lot of predisposition to cholesterol plaque building up in the artery wall and either narrowing or clogging or blocking the artery. So it's multiple factors and sometimes very difficult to tease out exactly which factor is contributing.
So demographics can play a role. Factors like plaque or hardening of the arteries, factors that are out of our control, like our age. But you also alluded to things we can control.
Tons of stuff we can control. So the most significant modifiable risk factor for both types of strokes is actually high blood pressure, we call hypertension. So management of high blood pressure is a really significant risk factor that we can address with medications. Other things would include smoking, diabetes, high cholesterol, obstructive sleep apnea, stress, sedentary lifestyle. It really shows the importance of having a primary care provider and getting regular medical care to address these modifiable risk factors.
That's reassuring because some of those things sound kind of like, I got high blood pressure. What am I going to do? It's just life, right? But if we can manage those things, if we're going in for our wellness checks, it's not an inevitability that we'll eventually have. hardened arteries or a stroke or whatnot. It's not necessarily going to be the end game.
Exactly. With medications and lifestyle changes, we can significantly reduce a person's risk of having a stroke.
Now, we've talked about ischemic and hemorrhagic stroke, but there is a third type of medical emergency I think we should talk about: transient ischemic attacks.
Yeah, so transient ischemic attacks, or people might call them TIAs, and actually what I hear my patients call them are mini strokes.
Oh, yeah, I've heard that term before.
So they're all interchangeable. And the whole idea here is these are very short-lived symptoms that we think are due to an interruption of blood flow to the brain, but it's so short that it doesn't cause brain cell death. Because if it's long, the brain cells will die. So it's these very transient and short-lived episodes. And the reason we care about them so much and why we want people not to ignore them is they're a very high-risk warning sign of an impending stroke. And so in the past, the definition of a TIA was a sign or symptom that we felt was due to interruption of blood flow to the brain, but all of the signs or symptoms went away within 24 hours. Now, we moved away from a time-based definition to a tissue-based definition, which means if we get imaging and we see that there's been cellular death or a stroke, we won't label that a TIA. We'll label that a stroke. But if you get the evaluation and there hasn't been any permanent brain damage, we do think that the signs or symptoms you experienced were due to an interruption of blood flow. We'll label that a TIA, and we will try to figure out why that happened to address it and reduce the risk of actually having a stroke. The risk of stroke following a TIA is highest in that time window right after the TIA. So it's really important to get prompt medical evaluation. And then again, about a third of people that have a TIA will go on to have a stroke.
So is it the case then, if I have a little tiny clot, that there's a risk that maybe there are more tiny clots or maybe even a big clot that are coming down the pike?
Yeah, that's correct.
Most of us are used to just hearing the term strokes, but there are actually two distinct types: ischemic and hemorrhagic. An ischemic stroke is when a blood clot occurs in the brain that prevents blood flow to brain cells, causing them to die. It's also the more common type. A hemorrhagic stroke is when there's a rupture in an artery in the brain, causing blood to flow into the brain. This type is usually more serious. There are some risk factors for stroke we can control, and some we can't. We can't change the fact that we get older or change our genes, but we can make sure we're managing any health conditions that increase stroke risk, like hypertension, and we can cultivate an active and healthy lifestyle. There are also transient ischemic attacks, also known as TIAs or mini strokes. These are temporary disruptions of blood flow to the brain that resolve fairly quickly. But you shouldn't disregard them just because they're short. They could indicate a bigger stroke is on the horizon. But how do you know if you or someone else is having a stroke? Let's get into that next. So we've talked about what's happening on the inside of the body. Let's talk now about what things look like from the outside. How can we spot if somebody near us is suffering from a stroke, or if we ourselves are suffering from a stroke?
These symptoms are going to occur suddenly, without warning, suddenly. And so if you have symptoms that come on all of a sudden, you should automatically be a little bit worried. And then the other component to think about is a stroke is going to occur in one side of the brain or the other. One side of our brain controls one half of our body. The other side of the brain controls the other half. And so if you're having symptoms that only affect one side of your body, that should be pretty concerning. And some of those things could be weakness, loss of sensation. You can get changes in your speech or language. And so we use the acronym FAST. And what that stands for is face, arm, speech, and then time, meaning it's really important to get to the emergency department and get assessed.
Hmm.
What that means is for face is you might look at somebody and see that one half of their face is drooping or weak.
Mm.
Ask them to smile and see if one side of the face doesn't move as well or doesn't elevate as high as the other. Next is arm, and that's to assess weakness. So you have them say, lift both of your arms up, and you're looking, does one arm not lift up at all? Does one arm kind of drift down? And it's speech. And all you have to do is ask them to say a simple sentence. We always think about speech as just talking, but speech is actually a combination of speech and language, and either or can be affected with a stroke. What I mean by speech is the motor function. So how I move my mouth, my tongue, the vocal cords, how I make the sounds, that's my speech.
Hmm.
And so you might hear somebody that sounds muffled or garbled or slurred. And that's can be a sign of a stroke. When we talk about language, that's actually the words and the meaning. And so somebody having a stroke might not understand you. They might have trouble following your directions, or they might be able to follow your directions, but when they talk to you, what comes out makes no sense.
Mm.
Sometimes people call it word salad.
Mhm.
And so if you see either a disturbance of speech or language, that's a concerning sign or symptom that somebody's having a stroke. And then for all of these, it's crucial to call 911 and get to the nearest emergency department to get assessed and get treatment as promptly as you can.
Now, are the symptoms more likely to show up on one side of the body or the other?
On the whole, no. A stroke can occur on either side of the brain and can occur in any part of the brain. There are certain areas that we do see strokes occur in more often, but that's due to more anatomical reasons. So, for example, there's an artery in the brain called the middle cerebral artery. It's the biggest and it carries the most area of the brain. So we do see more strokes in that area, but that's purely from an anatomical basis. Otherwise, strokes really can occur in a lot of different places.
Mm. And what about mini strokes? Are the symptoms going to look the same in a mini stroke?
The symptoms or signs of a mini stroke and an actual stroke will be identical.
Mhm.
The symptoms should go away quickly, but again, not a reason to not seek emergent medical evaluation.
So let's say we have a loved one who is showing symptoms. This is definitely a situation where we need to go to the hospital. We go there. What happens next?
Once you get into the emergency room, they are likely going to do a very quick assessment and realize this patient may be or is having a stroke. The emergency departments are going to have a protocol to really get the resources and the team around, because everybody knows that time is brain and that we have to act quickly. There's going to be a very brief information gathering. Some of our treatments depend on how long it's been since the symptoms started. So we're going to try and figure out when the stroke started or when the symptoms began. We're going to do a neurologic assessment to see what parts of the body are affected, how severe the stroke is. And then we're going to quickly do some basic lab work to make sure there's nothing else going on that impacts the eligibility for some of our stroke treatments, but also to make sure there's not something else going on that's mimicking or causing the stroke symptoms.
What are those other things that could be?
One example would be a seizure. So somebody can have a seizure and then afterwards look like they're weak on one side of the body or the other, or they can be confused all of a sudden. Rarely, some people with migraine headaches will have symptoms that can mimic a stroke. You can also have disturbances like of electrolytes or low blood sugar that can also mimic these symptoms. So we'll quickly do some tests and, of course, the physical exam and history and assessment to try to rule out or rule in one of these mimics.
Okay, so we've determined it's definitely a stroke. Now what?
Really quickly, we're going to go and get imaging of the brain. At most centers, that's going to be a CAT scan or a CT scan. At some centers, they'll go directly to an MRI scan. And we're going to quickly, through this imaging modality, determine if a patient is having an ischemic or a hemorrhagic stroke. That's an important distinction because, as you can imagine, the treatments vary quite differently between which type of stroke a patient is having.
Mm-hmm.
So for most centers, a CT scan will be able to quickly identify if there's any bleeding in the brain or not,
Mm-hmm.
and also rule that out to say that really what we're dealing with is an ischemic stroke.
And once you determine that, what happens next? What is the treatment for an ischemic stroke?
either by labs or history, will rule out contraindications to giving a patient a clot-busting medication. But if all that meets criteria, through an IV, they will be given a medication that can break apart a clot.
Mm.
And so the whole idea there is to give this medication, let it go into the bloodstream, let it go to the brain, break up the clot, and restore blood flow to that part of the brain as soon as possible.
Mm. Is surgery ever necessary?
Well, not surgery per se, but if there's a blockage in one of the large arteries in the brain, we can do what's called a thrombectomy or an endovascular procedure. And what that means is we'll actually go in, access an artery either in the arm or the groin, go up to the brain, and physically, with either a catheter or a device, remove the clot. People are probably familiar with doing some of those in the heart, very similar to what we do in the brain now, is we take the clot out and restore the blood flow.
Wow, that seems like a major step forward. Now, you mentioned earlier that time is important. How does that factor into all of this?
So as long as somebody comes to the emergency department within an eligible treatment time window, and that's been expanding. The current guidelines would suggest that we have up to 4.5 hours to administer the clot-busting medication. And the reason that we're strict on that timeline is that the medication can cause harm if given too late. The next we might be able to do is with some advanced imaging extended to 9 hours for the clot-busting medications.
Oh,
For select patients, if they've got a large blockage in the brain and they're within 24 hours, we're just going to take the clot out. Only a certain number of patients have that large artery blocked. Those are the most severe, disabling, and potentially life-altering or life-ending strokes. So it's those that we typically can intervene on up to 24 hours.
and I hate to look on the dark side here, but let's say it's been more than 9 hours or 15 hours or more than 20 hours and somebody hasn't received treatment in time. What happens then?
In those cases, even though there aren't the acute interventions, there's a lot of supportive care that we can do to try to minimize the size and extent of the stroke. And so a lot of that is going to be focused on the individual. And I'll give you some examples. If you're having a stroke, you might not be breathing or be able to protect your airway great. And we're going to help you with that, because if you're not getting oxygen into the lungs, you're not getting oxygen into your brain. We're going to make sure that the blood pressure is appropriate, that your fluid status is okay. A lot of those kinds of supportive measures to make sure that the damage that's happening can be limited as much as possible, even though you might not have been a candidate for one of those acute interventions.
That's great to know, because maybe some people just aren't going to make it in there by the 9-hour window or the 15-hour or 20-hour window. We have been talking about treating ischemic strokes. What about treating hemorrhagic strokes?
Treating hemorrhagic strokes is very different. Obviously, you do not want to give a clot-busting medication to a patient.
Oh, God, that's exactly the opposite of what you probably need, right?
Right. And truly, without imaging, we can't be sure which kind we are dealing with. The number of times where somebody says, I started having stroke syndrome, so I took a bunch of aspirin. That's not the right thing to do.
Oof. When I think of aspirin, I think I'm going to bleed out more.
Right. And so it might be okay if you're having the ischemic stroke, but if you're having the hemorrhagic stroke, taking aspirin is exactly what you do not want to do. And so, again, it's just more important to get to the nearest medical facility that can take care of you and not start administering medications yourself. In terms of actual treatment of a hemorrhagic stroke, it's often a little bit simpler. So we know that there's been a rupture in an artery. So think about all of a sudden a garden hose that's flowing. You're going to want to do one of two things. You're going to want to turn down the pressure in that hose. So we're going to want to lower their blood pressure if it's high. And it's the thickness of the water. So if somebody's on a blood thinning medication, we're going to want to give them a medication to reverse that. Occasionally, if there's certain types of hemorrhage, we might do a surgical procedure. There's minimally invasive surgical procedures where if we can get access and not do damage to the brain, we'll go in and try to remove the clot, remove some of that pressure. And occasionally, if there is pressure in the brain, we might put in a drain that actually relieves some of the pressure. Because again, you don't want too high a pressure in the skull.
Wow. To spot if someone is having a stroke, remember the acronym FAST: face, arm, speech, and time. These symptoms will usually occur suddenly and affect only one side of the body. If someone is having an ischemic stroke, doctors will do a series of evaluations and, if possible, administer a clot-busting medication to break up the blood clot and restore blood flow to the brain. But treatment for a hemorrhagic stroke is very different. Doctors will lower blood pressure, reverse any blood thinning, and sometimes even operate to alleviate pressure on the brain and skull. This is why it's super important not to self-administer aspirin if you think you could be having a stroke. If it's the hemorrhagic type, aspirin will actually make things worse. Your best course of action is to get to a hospital as soon as possible. Next, let's talk about life after a stroke, as well as how to prevent strokes from happening in the first place. All right, so hopefully we've survived all of this. Let's talk about what's next. And this is what you said you have some hope about. What does recovery look like for a typical patient?
It's very individualized. It's the location, it's the size, and it's the level of disability and severity that really is going to influence somebody's recovery and trajectory.
Mm-hmm.
How somebody's going to do is very much, was this stroke in a very high value part of the brain or less so?
What do you mean by high value part of the brain? I want my whole brain.
Maybe that's a pet peeve from a doctor because every part of my brain is important, right?
Yes.
There are parts of the brain that are going to be associated with more disability. If you happen to hit that part of the brain where the language center is and you're now not able to communicate, or if you are all of a sudden paralyzed on one side of your body, that's a huge level of disability.
Yeah.
The other part is, how healthy were you and how old were you when you had your stroke?
Mm-hmm.
So if you're very elderly and unwell and already frail, the recovery from that stroke is going to be much worse than if you were really young, healthy, vigorous. So just like in anything, how you were beforehand will absolutely influence your trajectory after one of these life-changing events.
So how does all that translate into treatment and rehabilitation?
Once somebody's admitted to the hospital, there are really two parallel teams involved in the care. So from the neurology standpoint, we're going to be doing diagnostic testing to figure out why the stroke happened. Strokes can occur for a number of reasons. And if we can pinpoint what caused that person's stroke, we can really make the decisions in terms of medications, lifestyle, maybe even surgeries, et cetera, to reduce that person's risk of having another stroke.
So you can determine like, oh, this was clearly a case of hypertension going untreated, for example.
In my grandfather's case, he needed to be on a blood thinner to prevent further clots in his heart. So you can really go after that cause and address it.
Mm-hmm.
In parallel, we'll typically then engage another specialty called physical medicine and rehabilitation. And they're the real experts in rehabilitation and recovery from a stroke. And that's going to be a multidisciplinary team who might involve a speech pathologist, an occupational therapist, a physical therapist.
And what kinds of recovery treatments is that other team going to give?
The physical medicine rehabilitation doctor is going to do an assessment and recommend a rehabilitation plan of care. And from that, they're going to determine which therapists are indicated and beneficial, and then cadence, frequency, intensity. So there is rehabilitation that will occur while the patient is in the hospital.
Mm-hmm.
And then when the patient is ready to discharge from the hospital, we'll have to determine what that looks like. So there are acute inpatient rehabilitation units where you will transition to one of those and you'll have very intensive multiple hours per day of rehabilitation. And these programs are phenomenal. We know that neuroplasticity and recovery can be some of the best and fastest early after a stroke.
Mm-hmm.
And so these are a great option if available and a patient can tolerate that level of intensity.
Mm-hmm.
If not, we might be looking at a skilled rehab facility where somebody might not be able to get that intensity, but still has access to the appropriate therapist.
Mm-hmm.
Best case, if somebody's able to go home and do those outpatients saying, all right, I'm going to see the physical therapist, or the therapist is going to come to my house, and those kinds of things. But the recovery can be involved and lengthy.
And what kinds of things do folks work on with those therapists?
How do I safely pivot? How do I walk? How can I use maybe a gait aid? How can I do stairs? How do I navigate a home environment? How do I do stuff in my kitchen? How do I manipulate objects? How do I get my motor dexterity back in my hands?
Yeah.
And then the speech pathologist is going to be working with, are there techniques that I can do to slow down and help enunciate my words so people can understand me better? If it's a language function, how can I help circuitry? Sometimes they'll have them sing, because singing can be a different pathway than just speaking.
Yeah.
Making these connections and really helping the brain find ways around the area of damage and make those connections reconnect to restore that function.
So it's really a multifaceted approach with a lot of skilled people, because the brain is a complex thing. The thing is, though, we all know that some people seem to make great recoveries from stroke and others do not. Why is that?
Again, it's really going to come down to, how was your health before the stroke? And then it's really going to depend on where the stroke happened in the brain, the size and the severity of the stroke. And of course, were you able to get to a medical center soon enough to get an acute treatment that could potentially alter the course of that stroke? Sometimes it just seems unfair. Sometimes you look at, well, so-and-so did great, but it's really one of those nuanced and unfortunately individualized situations.
Unfortunately, stroke rates are increasing. Do we know why, Dr. Klaas?
So this is kind of an area of interest and is evolving. We do see an increasing incidence in stroke recently, whereas before, in the last several decades, we're actually seeing a trend down. There's a lot of theories and literature out there on this. I think probably the simplest way to put it is, age is absolutely a factor. And so we see the baby boomers generation, there's just a lot more of them, and they're aging into their stroke risk years.
That makes sense.
Really, the more concerning trend, we saw the incidence in the younger population increasing. And that was really a consequence of a lot of unhealthy lifestyle factors, healthcare disparities, socioeconomic, and that obesity epidemic that we were dealing with. And we started to see patients with multiple of those modifiable vascular risk factors occurring at a younger and younger age.
What can all of us do now in our daily lives to reduce our risk of stroke in the future?
Very valuable to be mindful of all the modifiable risk factors. Very important to get that regular medical care so that you can catch these risk factors early and address them. And then from a general lifestyle thing, we know sedentary lifestyle is a major risk factor. We know that exercise is really good for us. The American Heart Association would recommend about 150 minutes of aerobic exercise a week. We also know diet and nutrition are important. We should all probably increase our fruits, vegetables, and whole grains, and really try to avoid a lot of those processed sugars or refined foods.
In addition to everything you just said there, are there additional things that people who've had a stroke before should do going forward for their health?
Yeah, so unfortunately, if you've had a stroke, you're at a higher risk of having a stroke. And so the most important, in addition to those risk factors that I talked about, is figure out why that individual had the stroke and making sure that risk factor is addressed or at least as reduced as much as possible.
Now, you said earlier that stroke treatment has advanced quite a bit, even over the course of your career, but there's more to come. What are those advancements in recovery that you're really looking forward to?
We are going to hit a level where we'll become like cardiology, who's really good at treating heart attacks. They know exactly how to do it, get somebody right from the ambulance into their treatment, open up the coronary artery. And I think we're going to really refine and perfect that. But I think the next frontier and where we're going to see the most advancement is probably in the field of recovery. On the horizon is a lot of opportunity for rehabilitation and recovery and huge advancements in that field. And I don't know exactly what's that going to look like, but there's a lot of new treatments on the horizon,
Mhm.
transcranial magnetic stimulation, vagal nerve stimulation, these other
Mm.
things that can really be game changers. We're also seeing the use of artificial intelligence and neuronal signaling, and people are able to use that with robotics. So a lot of stuff coming down the pipeline that will hopefully really make a meaningful impact in people's independence, recovery, and quality of life.
Hmm. Now, I would just love to end things on an upbeat note here. Do you have a success story of a patient that you could share with us?
I had a 65-year-old woman who had an episode where she had painless loss of vision in her left eye. And that can be a warning or a TIA or a mini stroke, and she ignored it. And about a week later, I met her in the emergency department where she was actually having a full stroke. So she had interruption in her speech and language, and she was paralyzed in her right face and her right arm. When we got the CT scan, there was no blood. The brain tissue looked healthy. We didn't see any signs of permanent stroke. And so she was able to receive the clot busting medication, and we took her immediately to remove the clot. And the second the clot was removed, everything was restored. We were able to figure out what caused her stroke. And she walked out of the hospital 2 days later and went right back home as if this had never happened.
Wow, that's incredible. That really speaks to being at the right place at the right time, getting immediate treatment, seeing the right doctors and so on. I think a lot of folks out there, when they hear stroke, all they think is, oh, that's it. That's it. But it doesn't sound like that has to be it at all.
No, we've got opportunities now.
Dr. Kloss, thank you so much for joining us today. I learned so much.
Oh, thank you guys.
Stroke recovery and rehabilitation can vary widely from person to person, depending on the severity of the stroke and where in the brain it took place. On the neurologist side, doctors want to identify and treat the cause of the stroke so that it doesn't cause another one. Then, physical rehabilitation medicine can include occupational therapy and speech pathology to help someone rebuild the connections in their brain and regain function. Stroke rates are increasing, but you can protect yourself by focusing on those modifiable risk factors: lifestyle, diet, exercise, and managing health conditions. Stroke treatment has come so far, and there's even more potential progress to be excited about. The hope is not only that doctors will improve and master acute interventions, but also that technology will open up new frontiers for recovery and rehabilitation. Okay, that's all for this episode. But if you've got a question, a topic suggestion, or a follow-up question about this episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Health Matters episodes and resources, head to mayoclinic.org/Health Matters. And if you found this show helpful, please subscribe and make sure to rate and review us in your podcast app. It really does help others find the show. Thanks for listening, and until next time, take care and stay healthy.